you, Dr. Naveen, for salvaging my talk today, without which this talk would not have been possible. Yeah, thank you. Okay, now my job has been very easy because the three speakers preceding me have told you a lot about stable, unstable, and what to do, and how to do a perfect nailing. Now the slide on the top, the picture has been borrowed from Synthes, so credit to them. Now, I don't need to talk too much about the classification, it's already been taught. So, what do we do in A1? DHS, by far, several level 1 studies show that that's the best implant. Now, this study from Norwegian registry shows clearly the superiority of the DHS over the IM nails. I mean, I'm deliberately using the word IM nail because PFN is a trademarked for a particular company. So, proximal femoral nails fare very poorly with reoperation rates significantly higher than the DHS in this particular series of more than 7,600 fractures, of which 1,300 were nailed. And they showed quite significant complications with the IM nail. For the A2, I think this article has already been shown by one of the previous speakers from the US. It's an RCT, randomized control, again, level 1 study, which shows that the sliding hip screw is far better even in A2. Now, other studies like Bandari et al., if you see the meta-analysis of the first decade of this century, there have been significant poor results with IM nails. That's probably because of the older generation gamma nails. If you see the meta-analysis of any IM nail literature, it's predominated by the gamma nail, which is made by Stryker. Unfortunately, is not available in India. But they had significant problems, the first and second generation, so the DHS always fared better. So most meta-analysis in the first decade of this century showed that the DHS is far superior to the nails, whereas this particular meta-analysis from Bandari from Toronto showed that IM nails were as good as the DHS, not superior, as good. Now this paper has also been briefly referred to by one of my previous speakers. It's a prospective randomized control, again, level 1 evidence, shows no difference in complication rates, outcomes. The only difference between the two, DHS and the IM nail, this is a gamma nail group, shows that the early weight bearing and slight patient satisfaction, which is much more in the nails, and hence the authors say a nail is a better option. Now, what do the National Health Service guidelines in the UK say about this? The NICE is an organization which tries to rationalize implant cost and benefit ratio to the patients, and hence their suggestion is to use the DHS wherever possible up to A2. Now, what about the A3 fractures? Now, there's no difference. Again, this is a Norwegian registry study where this is a remarkable study in the sense that they had about 700 patients and they treated A3 fractures were about 150, including subtrochanteric fractures, not IT fractures with subtrochanteric extensions, subtrochanteric fractures. And of the 21 subtroch fractures, 13 were treated with DHS with trochanteric stabilization plates and only 7 with nails. And again, no difference. And this is one of the registry data from Norway with very large numbers, so it cannot be just dismissed as an anomaly. And again, another meta-analysis which shows no difference in outcomes except for the better patient satisfaction and early weight bearing in the nail group, and hence they favor the nail. And this group studied only meta-analysis of all PFNs as made by Synthes. Again, the Germans did a survey of their own. This is 2 different articles from 2 different parts of Germany. And they showed, again, there's no difference if you use the DHS in A3 fractures with lateral stabilization plates, as they call it, versus the nails. But they found, again, early weight bearing is better in the nailing group. And these are the sort of fractures that you will have to make a decision on. And you do these PFNs. And then like that, and then you can see this is the immediate post-op, and you see cortex to cortex continuity, although in the lateral view it looks as if it's overlapping, and then it collapses, controlled collapse with no progression in the screws, the so-called Z or the reverse Z effect. with healing. This X-ray is 3 months post-op. Now, what about this A2 fracture with a lesser power? It's running out of battery. Now you have that lesser trochanter riding so high. Connect power cable. And then I chose to do this. I mean, the screws look as if it's converging, but you will soon see in the lateral view, it's diverging posteriorly. The cannulated cancellous derotation screw is placed posterior to gain that rotational stability. And so the two screws are diverging in one plane. And then that is, after healing, you can see that the lesser trochanter has been completely ignored and is still staying where it was at the time of trauma. Now, the Cochrane, this is the latest Cochrane meta-analysis, which shows again there is absolutely superiority of the DHS versus the nails. And this Cochrane meta-analysis involves all types of nails, all different companies. But again, there is a slight preponderance in functional outcome which seems to favor the nails, but not borne out with fracture complications or successful healing of the fractures. Now, so finally, what do you want to do? The DHS, what is it good for? All A1s and A2s. And the only study that I know so far which has studied what fractures do well at the DHS is measuring the lateral wall thickness, which has problems again because of projectional issues. But they feel, these authors feel that 20.5 millimeters is the optimum thickness for DHS to work very well. If you don't have the thickness, you can alternatively use the trochanteric buttress plate. Now, this is a typical fracture, lost power. For a minute, and then you have this. Not catastrophic, but what you don't want to see. The lateral view is imperative because the fracture should collapse on itself. If it is in direct alignment, then you probably won't have too much of collapse, and hopefully this is a 6-week PO. This is a recent X-ray, so I'm still waiting. Patient is walking. Of course, there is no restriction on the patient because it's quite elderly patient. But this can happen to you if you misjudge the thickness or the quality of the lateral wall. And hence, you should go for a rather center-center. You should adapt your technique to a center-low. Now, this is an interesting case which, whom this patient I had operated prior to this fracture, and patient was not in Hyderabad, and I suggested local surgeon can go ahead and do a IT fracture fixation whichever way he wanted, because it's a fairly straightforward fracture and doesn't need the patient to come all the way to Hyderabad for this. And this surgeon chose to do this implant. At 2 months, they were so worried, and I was getting calls from this surgeon, what should I do? Now, the natural instinct for you is to think, okay, I'm going to take this off and then do a revision surgery with another implant. Probably not, because the patient has bilateral knees and quite elderly and confined. Maybe I would have gone for a hemiarthroplasty, but the patient was terrified, and I said, okay, I'll wait, I'll see how this fares. And it's interesting, because not all cases go the way you think they go. Now, that's 5 months, that's 8 months. I just left it, I took it out. The fracture healed. Luckily for this patient, it didn't cut through, so patient is happy. Now, why are people increasingly using IM nails? It's been noticed in the US and it's been noticed in Germany, despite evidence to the contrary. In the US, obviously, there's money involved. And the other impact factor is technology seems to attract the younger surgeons much more than the older surgeons, who seem to know a lot more about the so-called recent advances. So nails are preferable in unstable injuries. So I'll show you some of these X-rays to show you some complications, especially with this one. Watch the bottom screw. Seems not collapsed. I was expecting it to have a Z effect because the fracture is collapsing, and control collapse. Now, this is another interesting case where you see the immediate post-op and you're happy. 7 weeks, the center bottom screw is going forward into the joint. This is the Z effect. This scares you because it can penetrate the joint. But luckily, again, 12 weeks, it stayed that way. The fracture had stabilized and healed. Sometimes you may have to go in and take that screw out if you think it's going to perforate the joint. The Z and the reverse Z. The reverse Z is where the screw comes out of the nail completely. I have not seen that. But one important thing is this fracture. If you misread the fracture and you misdo the nailing or DHS technique, you have terrific price to pay. The patient does. The surgeon, this is a very stable A2 fracture with a fracture of the lesser trochanter, probably A2-3. So you could have gone for a DHS, you would have probably got good fracture interposition and compression. Surgeon chose to do this, and the tip apex distance and the reduction is terrible. So both ways it's poorly done. So there's no surprise there. And regarding the screw versus helical blade, well, this randomized controlled trial from Switzerland shows there's absolutely no difference. The helical blade is superior in rotational stability compared to the screw, but it's got very poor pull-out strength. So catastrophically, if it fails catastrophically. So in summary, DHS is safe, A1, A2, but in A3, you have to do a meticulous reduction bone to bone and use a trochanteric buttress plate. IM nails, yes, example PFN, very useful in A3 if you're not comfortable doing a very difficult DHS, but still needs meticulous technique and reduction. And don't forget the tip apex distance. Thank you for your attention.